3. Once again, I encourage us to be brief.
Good afternoon, all. Simon Gondi is my name. I represent HEFON, Health Reform Foundation of Nigeria. Most of our work is that of advocating for government policy on health. The question is this. Are the clients, sorry, I'm directing my question more to Plateau. Do we think our clients are accessing services by our providers? Why I say this is, if a provider has an enrollment of about 1,000 persons, at the end of the month, how many people do you think access such services? Do we think because they were not sick, or is something keeping them away from accessing the service? Could it be the quality of service, or is there something we are not doing right? How much do we pay per client? Because I know some time back, it was a very serious problem because the providers, if they are not paid the right amount, it's either they are benefiting from clients that are not attending or coming for their services. So we must know why we have such problem. Because the essence of insurance is a shared burden on health so that we can reduce the out-of-pocket expenses. So if we are not achieving this thing, we must be able to say, why is it that the clients are not turning up? Penalties, and especially I think given the Director General of Plateau, we had some work done some years back, and we for Plateau to look at that. And if there's a way to encourage and strengthen that, because they do quite a lot for themselves. And if we find communities doing that, I think we shall go a very long way. In Plateau, I know there's a village in Shiwer. They had that, and it was very, very useful to the people. It helped them a lot, health-wise, and their out-of-pocket expenses was reduced largely. So thank you very much.
Please, once again, make it brief. While they are giving him the mic, just to remind us that this program is online. So please ensure you tell others so that they can participate. People are participating online.
All right. Thank you very much. My name is Dr. Yilji Kumtab Kashmaya. I'm a delegate of the Nigerian Medical Association. Permit me to commend the panelists for so eloquently and brilliantly presenting the facts before us. But like I've always maintained, the road to achieving Abuja Declaration, WHO Abuja Declaration, is practically one that we will not achieve if no practical and easy steps are provided. But how do you correlate sin taxation with a farmer who farms Irish potato, and then the Irish potato is used to produce whiskey? How do we tax the timber farmers who cut and fell down our trees, causing deforestation and having climate problems within the environment? So for me, I would say as much as sin taxation is a brilliant idea, we should toe the step of taxing practically every business as suggested by Professor Damen. So my question now is to the Ministry of Health. Do we have tax rebates, for instance, for businesses which give us or who venture into venture philanthropy? In Jude, for instance, an individual practical steps can must in collaboration with the State Internal Revenue Service, ensure that we tax every business and that fund is dedicated to the health sector. Else, we will never and we might not achieve the WHO declaration of 15% for the budget. Lastly, there are lots of pool in the private sector. How have we used for medical tourism? It's used for medical tourism. And unfortunately, our budget for 2025 in the health sector is about 1.6 trillion, less than what individuals carry abroad in search of medical health. So, if we must achieve that, we also need to understand that the business of the health sector is not entirely the business of government. The private sector needs to be involved. And what is the Ministry of Health trying to do to ensure that private businesses participate in the health sector? Thank you very much.
I think there's just one more, please. Straight to the point. Who is number 5?
Good afternoon, all. Services, hospital, and release of the phones. And also, I want to appreciate them for a great and wonderful suggestion in that company, which a significant majority have done that, and we are now moving down to the rural area. We know how the rural areas are actually poor, so we should not work to further impoverish them. What I want to say here is, it has come to our notice that there are some services, when you go to Plastema, they say, this one is not covered. They'll make a prescription and say, this drug is not in our essential list. So you find out, you end up, you have paid for Plastema, and you are not still paying out of pocket. I want you to give more clarity to that.
Thank you very much. Okay, so I think we'll redirect the questions. If I'm not mistaken, I think most of the questions are for State Ministry of Health and Plastema. Our time is very, very fast spent. Please, you will be very sharp. But before then, just so that we engage those that are online, the window, I will just read it. It says, thank you all for the presentations. To achieve universal health coverage, everyone is meant to be carried along, including the vulnerables, and prevent out-of-pocket funding of health. Cost of drugs and accessing care are actually driving patients away from orthodox care. In all the speeches, hardly was any mention made of mental health. Health is not complete without the 3 prongs upon which health stands, and mental health is pivotal to complete health. So a few issues which the Council must address: the integration of mental health into PHC, which is still yet to be fully implemented; increasing the number of mental health practitioners in Plateau State, which is very abysmal. Only 1 psychiatrist, very few psychiatric nurses are presently in the employment of the state. And then the domestication of mental health, a criminalization of attempted suicide, of attempted suicide, desk in the ministry. These are low-hanging fruits, just so that our online participants can know that we are seeing them. So please, Plastema and State Ministry of Health, very briefly respond. Thank you.
Okay, thank you very much for the questions. So I'm going to start responding in terms of data. The ministry has worked tirelessly alongside with the Federal Ministry of Health to implementing the data tools. We do know that we have some critical gaps, as it's not all health facilities that have these data tools readily available to collect this data. However, for those facilities that have the tools, we have been able to get essential data, and we have what we call the quarterly performance monitoring system, where we review scorecards. Now, this scorecard is from each facility. It's not just at the state level. So it's from the PHCs they collate their data, they validate it, put it into this to see what is really happening at the facility level. Also, we also have a resource desk. This year, last month, actually conducted a resource mobilization engagement. And the engagement was not just focused on sectors within the health, it was expanded to the banking sector, the military, the paramilitary, you know, how we can get resources beyond health. And I'm also happy to tell us that following that engagement, we were able to get feedbacks. People began to make commitments. Some persons began to pay. Vulnerable persons were able to say, okay, these are the things they are going to include in their planning for 2026. Then, regarding, okay, so also regarding the strategies we intend to put in place when it comes to quality of care. When we speak about quality of care, we were able to identify that it's not just one person that needs to contribute to improving care. We have so many factors involved. When we talk about data, data is also important because we need to know what is the projected population we're working with. The structures that are in place, is it going to be able to serve that population? So most of all these things, as we plan for our 2026 annual operational plan, we have actually interfaced with the LGA officers to make sure that their plan is targeted based on population as well as projected revenue. And all of this will make a cumulative plan when the Ministry of Health is aligning its plan for 2026. So we have that in place. And also further strategies that we intend to put is also the community ownership. We've talked about the human resource. We do not have all all specialties readily available. However, with community-based training, we hope that each LGA will be able to recommend someone that can be trained in school to achieving more quality human resource within the facilities. And yes, the ministry has actually started engaging key persons and private organizations. Like I said, the resource engagement actually incorporated a lot of private organizations to see how we can better include them in our planning to achieve improved quality health care. Thank you.
Okay. All right, thank you very much. So, Dr. Morena has laid a very solid background on which I can build on in response to the questions that are directed to me. Now, first about the implementation of one basket for all partners that would want to invest in the health system in Plateau State. I think with the commencement of the operationalization of the swap approach to health, which Dr. Morena chairs, it has formed a very solid background. Such engagements are ongoing. And if you ask me, I would say that bringing everybody together would actually give us better outcome rather than getting a partner who would bring funds to eliminate 60% of malaria and allowing government to invest in the 40% of malaria. If you solve malaria, what happens to respiratory tract infections? What happens to chronic non-communicable diseases? So it will be more beneficial when you have a holistic approach to the health system, which the swap approach seeks to achieve. In my estimation, that would be a better approach to strengthening our health system. Now, secondly, about the low utilization among enrollees of a prepayment system, like what we run at the agency. Quite recently, when we conducted a utilization research, we discovered that among our enrollees, the utilization is about 8%. However, universally, it has been acclaimed that for a very sound operating system, 10 to 12% utilization is plausible among enrollees. So when we have enrollees, if a facility has, for example, 1,000 enrollees, we don't expect all the 1,000 enrollees to access care at the same time. And that, of course, aligns with the principle of risk sharing as well as cost sharing within the pool of the health system. I also align with you when you talked about the issue of deepening community contributions into health insurance. You recall that while I was making my contribution during the main discussion, I talked about the agency's desire to design smart community-based health insurance schemes together with the communities with the principle of community ownership with support and subsidy from the agency utilizing the equity health fund as it is currently being practiced at the agency to take over referrals. So communities will encourage communities to organize themselves in pockets where they can fund their primary care access, treatment of malaria, prevention of diseases, health education, health promotion, and the likes. Those can actually be funded by local communities. We're currently designing the process, and then when members of communities have issues that will require referral, for example, a woman in the community requiring a cesarean session, then the agency would actually take over from there using the equity funds that we intend to glean from the state government. So we are in full sync thinking about community involvement in contribution to the health insurance. Now about taxation, you would recall that while I was making a presentation earlier, I talked about taxing businesses, which aligns with what the NMA chairman actually suggested. However, we would have to really stratify the businesses so that a small business owner or a local farmer, a peasant farmer, in the village should not actually be included. If you have individuals based on their annual return on investments, we can actually hypothecate them into a marking taxation for the purposes of deepening health insurance. So by doing that, we would not further impoverish rural poor, just like what has been brought up by another contributor. Now, the issue of enrollees of the scheme not accessing some services and erroneously conceived as actually the agency rendering poor quality services to enrollees. I would like to say at this point that now the agency actually sells benefit package to its enrollees. Now these benefit packages, or this benefit package as a matter of fact, is usually clearly designed using evidence to meet the required needs of the people and environment. And I would like to say that the benefit package being delivered to the people of Plateau State by the scheme covers more than 95% of the common medical needs or health needs of the people of Plateau State. Where we usually have differences with the demand-sided population is that sometimes individuals or enrollees go to access care, and what they demand from the service providers is that they want branded medicines. For example, you go to the facility, a doctor prescribes amoxicillin clavulanic acid for you to access in the facility. However, an enrollee will say, I want augmentin. We don't administer brands, but we administer medicines in their generic forms. So when such conversations happen, it's usually conceived as if it is poor quality care. So it is our responsibility to continue to sensitize and educate our beneficiary population to understand the dichotomy that exists between branded services as well as generic services. Because in the real sense of the word, both generic and branded actually offer the same thing eventually when enrollees go to access care. That is not to say that, just like I said, it's not every service that is covered. But of course, the services that are excluded are actually quite few. So I'd like to say that our beneficiaries should really make the best of the services that we render to the scheme. I forgot to actually mention something quite earlier when I was discussing. I'd like to appreciate the local government chairmen who are quite seated here. They have actually been quite supportive to deepening health insurance here in Plateau State. As a matter of fact, at the moment, we are currently enrolling poor and vulnerable individuals across the 17 local governments of Plateau State by virtue of funds paid to the agency by the local government chairman. Thank you very much.
Okay, thank you so much. On behalf of the panelists, I would like Dr. Prof. Usa to just give us a 30-second That's for the panelists.
Yeah, thank you very much, the moderator.
No, I'll give you speak last. I didn't want to.
Thank you, moderator. I think this topic is very pertinent because out of the 6 building blocks of the health system, the biggest that poses the most barrier to entry is financing. So we cannot overemphasize this. So it's good. In discussing the resource constraint in the health system, we've looked at one component. It actually has 2 components. We've looked at the funding, but we've not been able to talk about the efficiency, and that we deal with the inefficiencies in the system, because even the little that is released to the system is not efficiently used. So that also becomes a constraint for resource or for funding in the health system. So we have to, going forward, and after this meeting, we also have to look at those leakages in the system, in the Ministry of Health, that leak the little that we have, and we are not able to use, to help population outcomes. And that also has to include things like the pervasive corruption we have in Nigeria. That plagues everywhere. Thank you very much.
Thank you. Our host, the Honorable Commissioner of Health, wants to have a word. I didn't want anybody to speak again after you, and that was why. So please, if he will give us the last word.
No. So thank you very much. I wanted to say something with respect to some of the issues around the ministry. She has tried very well, but we need to get some more things in perspective. Now, not too long ago, while we were arranging or preparing for this meeting, we had a meeting with all our partners, and we agreed that going forward, all partners must align whatever program they are doing with what the state is also planning. And so we made it mandatory that either monthly or quarterly, we should see their performance. And so hello? Is it better now? Sorry, the mic is messing up. And so we all agreed that we should work together in that perspective. And so what you have asked is critical. And so going forward, I think we are going to have that reorientation. We are not collecting the money, but we need to see in terms of performance and what exactly they are doing. Yes, the question Professor Yulguan asked about quality of care, very important too. You will realize that one of the things that we did recently, deliberately, was while we were trying to recruit for the PHC, we made it like performance-based. You will know that at most of our PHCs currently, majority of our staff are actually volunteers. And in trying to volunteer, the biggest culprit, the ES is here, he can confirm that, our directors of health in the local government, when they are putting people as volunteers, the chairman will bring some of the people he knows that may not have the real qualification. Some, maybe they are chemistry, biology, they say they did science, they can work. And so they deploy them as laboratory technicians. And environmental health is doing antenatal, taking delivery, and all that. And so that is where we are hitting the biggest problem in our PHCs. And so we have agreed in principle that whoever we are going to be employing from now going forward should be somebody qualified to actually do what he or she is supposed to do. And so midwives, nurses, lab technicians, scientists, and all that we recently advertised is to fill the gap. Out of over 1,500 volunteers that we had in the PHCs, only about 500 have the required qualification. So you can imagine the havoc that is going on. And so let us also be mindful when we are seeking for people to be employed. And I want to sincerely appeal to our chairman, because sometimes they have the resources that they are the ones paying. And so if you refuse to employ one or two of their relations, they will be angry. Maybe they don't have the qualification. But the truth is that we think that that system should change. So to enhance quality, we need to get all of this right. The other aspect about quality is the equipment that are available. Quite a number of things are lacking. And so with the revitalization and some of the things that are going on, the Primary Healthcare Board is doing a lot to ensure that some necessary things are made available. That way, quality will improve and our people will benefit more. I agree with you. We need private sector engagement. Private sector engagement, the swap desk office have been doing a lot in that. We had this session where His Excellency was present. We engaged with people from the banks, from road safety, from transport owners, from pharmaceutical companies, a lot of stakeholders. And the aim was for them to see how they can commit themselves to assisting us move the health system forward. A number of them have brought proposals, and we think that when those proposals are looked at, they will help us in so many ways. And so the tax issue, the difficulty about taxation is that the state's internal revenue, in terms of collecting tax, definitely, even when you have other compounding issues in the state, and so narrowing it to just health sometimes is a little bit difficult. But I think about a week or two ago, they called some of our key officers to talk on how best our revenue can improve so that we can also begin to do some more things. And leveraging on that, I think we are going to be doing a lot. So I want to specifically, truly, the Algon chairman is here. I want to thank you, sir, for what you are doing, particularly with respect to health insurance. I just got information. My local government chairman, who is here, is enrolling about 500 citizens of Kwampan local government. Please let us clap for him. It is not easy, but as much as you people are doing, I think that it will help our people a lot. It's a way of empowering them. When they are able to access care, it will go a long way to help the healthcare delivery. So I want to thank all of you, the panelists. I think I'm done. I really think that this was a very good selection. Thank you so much.
Thank you very much, Honorable Commissioner. I know many comments and contributions are coming in, but I'm so sorry we are out of time. They've been signaling me since. So I'd just like us to please, I will forward your comments to the Honorable Commissioner, who is the host, so that he will take note of what contributions we're making. So let's just give a round of applause to all our panelists as they leave the stage. Thank you very much. I'll hand over to our...
Please, ladies and gentlemen, can you put your hands together for Professor Maina? That was very beautiful moderating. And once again, let's put our hands together for the panelists. Each and every one of them was forthcoming with information. And put your hands together for yourselves for listening very well and for also contributing by sending your questions and comments. Thank you so much, each and every one. In no time, we will be leaving. But quickly, before anything happens, so that we do not waste time, we're going to be bringing up the next person who would speak. He's an associate professor of political sociology and the Department of in the Department of Social Sciences, University of Jos. He has published widely in both international and local journals. He is currently the head of Department Sociology, which houses sociology, criminology, and security studies and social works. He is married to Joy Wika and blessed with two sons. Ladies and gentlemen, please let's put our hands together and welcome Dr. Peter N. Wika for the next presentation.
Thank you very much for this session. I will be very brief. I was asked to speak for just 20 minutes. I am here to represent our rural communities. The topic given to me is on cultural beliefs and attitudes towards maternal, infant, child care, and also, please, can I have the slides, please? Cultural beliefs that informed health-seeking behavior in maternal health, newborns, and also child care. You will agree with me that most of the health challenges facing us, even as a state, have their rootings on the social interactions that takes place within the society. Most of what we see as health challenges are rooted even in our cultures, and more especially the health-seeking behaviors that we have in our rural communities are deeply embedded in such cultures. Permit me to start with the challenges, then the major drivers, and so we delve into the cultural beliefs and the attitudes. I have just very few slides that I feel very important to draw your attentions to. Now, Plateau State faces significant challenges in terms of maternal, newborn, and child mortality. The data I actually have here has been overtaken by what Prof. drew our attention earlier. And part of the problem is that we lack credible data around these issues. And at the center of this, you have harmful cultural beliefs and attitudes that are contributory to this high rate of mortalities. Now, within the rural areas, the major drivers, and a lot of you will agree with me, the major drivers within the rural areas is lack of education. And it's not just formal education. The context here is healthcare illiteracy. In the rural areas, this has remained a very huge challenge. Many people are not generally educated, and when it comes to health illiteracy, it is also a huge challenge. And so you can establish the relationship between cultural beliefs and attitudes when it comes to health-seeking behaviors in these key areas. Poverty also is endemic, and a lot has been said. And within the context of the rural areas, when we are talking of poverty, mainly we are talking about accessing healthcare services. And many of our rural poor do not have the social capital to access these critical healthcare services, even when they are available. Personnel, because the health system has been designed, so to speak, to only address the urban centers. Little or no attention has been placed on the rural communities. And so you have insufficient qualified healthcare personnel. You have rural areas, even in some general hospitals in Plateau State. Most of them, I stand to be corrected, may not even boast of 5 trained medical doctors, let alone our primary healthcare center. So that remains a very major driver in pushing the rural communities to seek alternative, and in most cases, harmful alternatives when it comes to accessing maternal health, health for the newborn, and even child health. Government inadequate funding is also a very key challenge. Now, if we must understand the challenge faced by these rural areas, communities, and these rural dwellers in terms of allowing their culture and beliefs to inform their health-seeking behaviors, then we must understand what culture really is. Understanding culture and understanding beliefs around this culture now informs why their health-seeking behaviors are mostly domiciled within these traditional healthcare providers rather than the modern healthcare. Now, culture is loosely defined as a way of life of a people. And beliefs are generally seen as an accepted fact, an opinion, or an assertion as real or true. Now, oftentimes such beliefs admits the slightest suspicion, and they take it as an assurance. Now, a belief can be seen as an ideology. This is what the people have grown up as a way of life. When it comes to maternal health, there are certain cultural beliefs around that. When it comes to how newborns are treated, and when it comes to critical health services that newborns should have, a lot of these ruralites will want to dwell on what culture has given them and what they have believed over the years. And so that remains a very huge challenge. And if we understand such context, we will now understand the complex interplay between what culture has presented and what has been believed upon in terms of health-seeking behavior of these ruralites when it comes to maternal health, when it comes to the health of the newborn, and also when it comes to child health. Sorry. Cultural groups. And many of them have their unique cultural practices as well as their beliefs. If you travel from Basa to Mangu to Kwampan, different cultures with different traditions and different health-seeking behavior, which has contributed to the statistics that was earlier on given when it comes to high mortality rates. Now, what has contributed more to this is the unique nature of the socio-economic context within the rural areas. They have no or little access to education. They have very little access to modern health care. So what is left at their disposal is to patronize what is available, what has been provided by culture, and what has been there over the years in terms of their beliefs. Now, in specific terms, there are certain practices that in terms of maternal health, certain traditional beliefs have informed a lot of attitudes. For instance, it is common knowledge in most of our rural areas in Plateau State that you don't even disclose pregnancies. When a woman is pregnant, there are certain cultural beliefs that once you expose that, you are liable to spiritual attacks, so you keep it within yourself. So, such myths around early disclosures, they believe it attracts a lot of spirits, maybe witches and wizards, and so as a result of that, even in terms of their abilities to seek for very early antenatal care is absent. And oftentimes, it comes with a lot of complications. There are also, within our cultural context, dietary restrictions. A lot of diets are seen as taboos in our local communities. And so certain foods are forbidden by either pregnant women, the very young, children, as well as those that are growing up. So in some societies, as simple as eating of eggs, which we know has a very good nutritious value to the pregnant women, is restricted. Certain meats are also restricted, and the belief around that is that when you are allowed to take such, you are likely to have very large babies, which may have complications during childbirth and all of such. We also have the traditional birth attendants in most of our rural areas. And because of the poverty levels, and because of the trust level, and because of the belief that has been built over the years through our cultures, most of our rural dwellers will prefer the services of these traditional birth attendants. And most of them lack the basic hygienic, they lack the basic medical knowledge in giving such accesses. And most especially because access to primary health care, and we have mentioned that several times here, is limited in such rural areas. You have them prefer to patronize these traditional birth attendants. Now, in some communities, there are also rituals around childbirth. Once a baby is given birth to, some rituals are performed. And in most cases, these are done in very unhygienic situations and practices. In some cases, herbal concoctions are given, either to hasten child delivery, or when a newborn is given birth to, certain concoctions are prepared. In some extreme cases, the newborns are even taken away from the mother for some hours or close to a day for certain rituals to be performed. And such often comes with a lot of health implications. Now, there are a lot of superstitions and rituals around that, such as the naming ceremonies. Some will take their time preparing for naming ceremonies, and the basic health care, the basic health need of the newborn is always neglected. There's also this belief around the umbilical cord when a newborn is being given birth to. Some see the umbilical cord as a link to the ancestors. And so there are certain harmful health practices that may eventually be harmful to these newborns and thereby increasing in this high rate of fatalities. There's this common belief, even within communities in Plateau State, that the first breast milk is often seen as that which is dirty. So in most cases, that is being taken out. And ironically, that is the most important that any newborn should have because it is rich in nutrients and also other antibodies. There are, of course, other rituals associated with male baby rituals. Now, there are a lot of consequences as a result of that. Now, a lot of these cultural practices and the sad narration in rural areas. And if we allow them to go ahead and follow the dictates of their cultures and follow the dictates of their beliefs, which may not necessarily be right and healthy, a lot of consequences will follow. First, there is this belief among the rural dwellers, even in the state, that illnesses are almost always attributed to maybe punishments from God or from some deities or maybe some ancestors. So when you are sick, rather than seeking the appropriate health services, they prefer to attribute such illnesses to other causes. And because they are rooted in what has been passed over time and built over by these beliefs, you have high rate of mortalities. For the maternal health care, the right health professionals, they prefer to meet spiritual leaders and other traditional health leaders. And if they do so, it has increased tremendously in the fatality rates that we now have. Now, there are certain myths. Again, Plateau as a state and the rural communities share in that when it comes to immunization. And because of the low level of health illiteracy, we have discovered that in some communities, vaccine hesitancy is still very, very, don't have access to health illiteracy. And so when such immunizations are brought to such communities, it is often rejected vehemently. And you know, there are certain experiences also with these immunizations where some of them were introduced with some fatalities. You remember the case in Kano some years ago and all that. So, such scenarios, and with the culture of these people and the belief systems that they have built over the years, and with the misinformation or low level of information around what are immunizations meant for, I mean, what do they stand to present in terms of quality health care, most of the rural dwellers will decide not to imbibe on that. Now, there's this very serious issue that concerns either the new birth or children under the age of 5. Now, when children come up with certain health conditions, especially cerebral palsy or some physical deformities, there are communities in Plateau State that such children are not even presented for others to even see, let alone to access health care. They are seen as evil children. And in most cases, you have cases of child neglect, and in some cases, you also have issues of infanticide, where such children are deliberately starved to death, or some of them are even killed outrightly. These beliefs are anchored on the culture of these people and the belief systems that they have built over the time. Now, how can we address these challenges? A lot has been said on community engagement. We have to create synergy with the traditional and the religious leaders. The Bongom Jos was here earlier on, and he said the organizers have to deliberately sit with the traditional leaders, and I think that's the best way to go. We must also develop a culturally sensitive health education programs. Culture is key, belief is key, and if we develop interventions that are culturally sensitive, that will go a long way in solving these issues. Now, antenatal care, of course, has to be looked upon. We must seek ways to dispel these harmful myths with targeted education and enlightenment, especially in our rural communities. The state representative here mentioned training and equipping of even the traditional birth attendants with modern health skills in order to bridge such gaps. Now, we must also create effective bridges with the formal health care within our traditional setting. A lot has been said about funding, so that issues that relates to the culture and the beliefs of the people will be adequately factored in as we develop that. Now, how do we revitalize this? A lot has been said from the World Health Organization, from the state representative. Infrastructure is key, not the top-bottom approach. Now, these issues must be approached with cultural sensitivity, respect, and also collaboration. We must avoid outright condemnation. In as much as we want to correct what has been built over time via our culture and belief systems, we must do that without outrightly condemning the process. And so with time, we can buy these people in. What are the key takeaways? Cultural beliefs significantly impact on maternal and child health outcomes, especially within our rural settings. Now, we must explore an integrated approach that combines both the traditional as well as the modern. We cannot discard the traditional at this stage. Over the years, over time, we can do that, but at the moment, we cannot. Community engagement is still very key. What are the steps for us to take in order to address this in terms of policy and the rest of them? We must conduct a comprehensive ethnographic research. We all agree that we don't have data. We don't even have the information on what we seek to provide intervention. So, research, very key. Ethnographic researches that are rooted in cultural sensitivities must be conducted around these key areas. We must also develop culturally appropriate interventions. Anything short of that, the rural communities are likely not going to be brought on board. Of course, we must strengthen primary health care infrastructure. A lot of our discussions, a lot of our attentions are centered in the urban centers. The rural areas will need a lot of such interventions and create lasting partnerships with traditional leaders. If we want to bring the rural communities on board, then the traditional leaders are key. And we must design policies with the rural dwellers on the table. Then they will take ownership and the implementation becomes very, very easy. Thank you very much.
Mic check. Can we please put our hands together for Dr. Wika? Thank you very much. You notice I constantly avoid the podium for very obvious reasons, so please pardon me. Please, ladies and gentlemen, we want to take on the next item, but then we would like to take that before we go for our lunch. And it was unanimously decided that we would take that, then after the lunch, we would go and reconvene tomorrow. Is that okay? All right. Very well. So, ladies and gentlemen, we'd like to do the next bidding, and then we would invite Kempia to come up and tell us what is going to happen next.
Thank you, Kaskida. Thank you so much for your patience and the contribution. The last panel conversation was charged and engaging. So I just want you to sit back and be patient for us to take the next panel discussion, which is going to be moderated by pharmacist M. Lenka. Please put your hands together for him as he walks up to the podium, and he will do well to introduce the other panelists. This panel discussion is going to be on human resources for health, a key criterion for achieving universal health coverage. Please sit back and be patient. Just after that, we'll have our lunch, and it's done for today. Thank you so much.
Okay. Thank you very much, and good afternoon, everyone. I can use the sound. Okay. It is said that universal health coverage is a stool that is standing on 3 legs. You have the medicines and health commodities, you have the financing, and you have the human resource for health. And I bet you, if you remove one of the legs, which is the human resource for health, I don't know if you will be able to sit on it for long. And on that note, our topic for discussion today, or this afternoon, is human resources for health, a key criterion for achieving universal health coverage. Human resources, like I said, is central to achieving universal health coverage. The discussion this afternoon is going to identify the critical human resource for health gap and affecting the universal health coverage. It will also highlight innovative strategies for human resource development, distribution, and retention, among others, or human resource for health. Well, I'm very happy that there is no shortage for the panelists to discuss this topic. Otherwise, I will be the one to be answering, or there will be task shifting for me to answer the questions by myself. So on that note, the panelists have been carefully selected based on their expertise and experience. And I'm going to call them not in any particular order. Okay, we have Dr. Raymond Jurid, the Executive Secretary, Plateau State Primary Healthcare Board. We also have Dr. Bishman Stephen Polycarp, Director of Medical Services, State Ministry of Health. Planning, Research, Statistics, Planning, Research and Statistics, Plateau State Hospitals Management Board. We have Professor Moses Chingle, Department of Community Medicine, Professor of Epidemiology and Primary Healthcare, University of Jos. We also So I think I'm going to stand from here to move on to go on with the questions. I will beg to start with the State Ministry of Health. Dr. Bishman, universal health coverage is not possible without adequately motivated and equitably distributed workforce. And like I said in my opening statement, it is one of the cardinal legs of the universal health coverage. Are we adequately staffed to meet population needs?
Thank you very much. The answer is a big no. We're not there. We really are not there. You'll agree with me that health, when we talk about sources for health, you see, the individuals, so all the persons, everybody who engages in actions that are primarily intended to improve health. These are just the persons we talk about when we talk of human resources for health. The World Health Organization gives us a 4.47 per 1,000 population if we really want to achieve universal health coverage. And of course, by extension, the Sustainable Development Goal 3, which is good and well-being. That common reference benchmark of 1,000, one doctor per, the population of Plateau State is about 4.7 million. And by then it was projected that by now we should have hit the 5 million. Yes. It will surprise you that 250 primary healthcare facilities we have on the plateau. Just about 33% of them are almost meeting the level 2 criteria for a PhD. What is this level 2 criteria we're talking about? And of course, when we talk the gap, the major gap in achieving that level 2 is human resource for health. And what is the gap? It is expected that before a primary healthcare facility attains that level 2, we should have at least one medical doctor. If there is none, at least one community health officer within it. Secondly, we should have at least 2 to 3 nurses or midwives in the facility. And of course, thirdly, we should have at least 2 to 3 community health extension workers within the facility. And I tell you, about 67% of the 1,250 PHCs we have lack this healthcare worker force we're talking about. This is where we find ourselves at the local government level. When you get to the secondary care facility level, it is another issue. Of the about 18, 19 secondary health facilities that we have, I think only one can boast of having like 4 doctors and the minimum requirement of nurses and midwives within facilities. Just one. This is as serious as it is. Wow. It is sad that most of the secondary health facilities, the nurses there run 2 shifts. They come in the morning and leave in the evening. The next people come in the evening and pass the night till the following morning. This is how serious it is. Our secondary health facilities are with the JAPA syndrome, both internal JAPA and external JAPA. Doctors come in, spend 6 months, 1 year, the next time, or gap pop up, open space, they all move. This is the problem. This is the situation we are in. That is the level we find ourselves in terms of human resource for health at the plateau. Thank you very much.
Thank you very much, sir. Yes, he has said that it's very obvious that there's very huge gap in resources for health in the public health sector in Plateau State. I would like to state that my panelists, if you can keep your responses straight to the point and use the minimal time you can use because of time. People are tired, just like the human resources for health are also fatigued because they are not, I don't want these people to be fatigued too. Thank you very much. So on that note, there, the Executive Secretary, Primary Healthcare Board, scaling up training institutions and introducing tax shifting are some of the strategies, okay, resource-limited settings like ours, utilized to address workforce shortages. Are we training the right cadres in the right numbers?
I'll be brief, but permit me to add to what he said. You know, I have to be biased. I represent the primary healthcare system in the state. So let me put it this way. The situation is very, very bad. My chairman are here. We've worked extensively on, working together to identify a lot of gaps. Some times ago, maybe a little bit more than a year, we put up a committee which was headed by the chairman for Shandam local government area to identify the challenges in the primary healthcare system. And I'll tell you that the gaps for human resource for health in Plateau State was identified at 11,000. 11,000. In 2015, in 2015, I was the executive secretary of the Primary Healthcare Board. By then, we had a human resource for health that totaled up to 13,000. When I 4,000 from 13,000. Out of that 4,000, about 1,500 are volunteers. So the gap that was identified, the committee recommended that we need to add 4,774 health workers at the right mix. An assessment again was done using the criteria of human resource for health, infrastructure of the PSCs, and equipment at the PSC facilities. So we use those factors to determine the functionality of our PSCs. we identified 890 health facilities. Less than 1% are in level 3. About 85% are in level 1. Now you can see what we have at level 2. A level 1 facility is not capable of giving our communities any qualitative PAC services. Just not possible, because they cannot even operate for 24 hours. So that's the situation we find ourselves. To attack or to better this situation, a lot of things have been done, even as I talk now. We are at the point of employing 1,450 health workers, doctors, nurse midwives, laboratorians, chiefs, and JCHIFs. But the most important thing is that 80% of those to be employed are going to be skilled bed attendants. This is being deliberate because you remember our maternal mortality ratio is very, very high. 905 per 100,000 beds. And of course, our infant mortality rate is not any better. So presently, we're at the point of recruiting that number. Last week too, we signed an MOU with the federal government for us to add another about 350 skilled bed attendants. So hopefully, and God's willing, we'll be having something close to 1,000. But the other good news is that His Excellency has promised to add another 1,500 early next year. I think these are good news. Probably we're approaching the 4,774 which your committee, sir, recommended. We're moving there. So to your question, whether we're training them, let me tell you that even though we do not have the health workers, the necessary mix, we have been able to initiate trainings. Specialists that have been trained so that they can train our SBAs. In fact, as I'm talking to you now, we've written a memo to His Excellency so that the Life-Saving Skills Center, which is domiciled at the Plateau Specialist Hospital, is upgraded, renovated, because you know it was given to us by the Health System Development Project in the early 2000 for the purpose of training our skilled bed attendants. I'm hopeful that His Excellency will approve this memo. Once he does that, it's going to be a continuous process. We have about 20 rooms there. The skilled bed attendants are supposed to come over to Plateau Hospital. They're supposed to be accommodated there. They're supposed to be fed there. They have a kitchen, they have a hall, and about 20 rooms. It is deliberate that they train there and they have to sleep there so that in case of any emergency at night, they are being called upon to witness it and practice. So they will repeat, cascade the same process at the local government levels. So in conclusion, I think that we've done.
Sir, we appreciate your efforts towards training, and really the numbers you have stated is very encouraging. Dr. Kefas, Hospital Management Board, recruitment, motivation, and retention are some of the strategies to keep our workforce in service. Why are health workers leaving? And how do we retain them?
So, thank you so much for the questions. And I think it's important we put perspective to issues with regard to human resource for health. My colleague has earlier attempted to actually define what human resource for health is. This includes all persons or individuals that are involved in any action or activities that is intended to improve health. Retention basically has to do with the skill, manpower that we have. I think more importantly is the doctors and the nurses that are migrating and leaving the country every minute. And I think that it is important. Let me say at this point that it takes a lot of courage for a professional healthcare worker right now to remain in Nigeria. Every day, the reason that people migrate is increasing. And some of these reasons are not far-fetched, which every one of us knows, are the issue that has to do with low pay and, of course, irregular salary has been in the front burner in terms of ensuring that healthcare workers remain in the country. And looking at what is happening in the country as well as in Plateau State, I think, as I said, it takes a lot of courage. When I look at some of my teachers who are here and have spent 20, 30 years in the health profession and have trained themselves, and I look at what they take home compared to what a Nigerian trained doctor who has traveled overseas is earning. I think what he earns in 1 month, you know, a professor of medicine in Nigeria, it will take him 1.5 years to earn that. Because by the time you convert $20,000 to $25,000 into Nigerian currency, that's well over 30 million naira. And if you put the salary of my teachers, you know, for 1 year, it's not up to that. And so that is a very finish. He had an appointment in one of the federal medical center. And having employed in that federal an ultrasound machine and an x-ray machine. And after working for 6 months, he called me. He said, I'm getting rotten here. Right now, as I talk with you, he's in Saudi Arabia. And extended to this crisis is actually the migration of our well-trained professionals and teachers. Our professors are leaving. And the basic reason is because they actually want to have a better experience as to leave. It's a mismatch that happens, you know, after graduation and then getting available job for you to work. So you have young doctors finished and they have to wait close to 1 year, waiting to even do a housemanship, you know, not to talk about getting employed. And of course, they use those periods to begin to write exams and plan to leave the country. So more to say in environment like Plateau State, let's not put aside the issue of insecurity. You know, we've had in Zamfara and in other states where healthcare workers are being kidnapped, some of them adopted, and they have to stay for 6, 12 months. Those insecurity are adding up to the push factor that is making healthcare workers to leave the country. So if I want to say, how do we retain healthcare workers? My colleague has said that this migration is actually both intra and inter. And I think that it is something that is critical because the healthcare workers or the human resource of health is central to the functioning of all the building blocks that we have in the WHO framework for the health system to work. So we need to make extra effort to ensure that we keep our health force. How do we need to do? We need a reform in terms of our pay. We need the government to look at it critically. We also need a great support in terms of ensuring that those doctors or healthcare workers that are posted to the periphery are supported by incentives, to be able to work there. So I want to cite an example with myself. When I finished up some years ago as a young doctor, I picked an appointment to work with the state government, and I was posted to one of the hinterlands to begin to work. And I noticed that while there, I was seeing more patients. I didn't have the opportunity that my colleagues here in Jos had. Yet those of them that are in Jos who are working in Jos University Teaching Hospital receive more paid than myself who is working in the hinterland. And of course, it became a motivation for me to find a way to leave that area and come to Jos. And so I want to appeal to our government, and I pray that this Council on Health come up with incentive measures that will be able to help our healthcare workers in the periphery, to have some kind of benefits that will enable them to work. And then also just to say that it is also very important and it is critical that we equipped our hospital. One of the things we are doing is to show that it is not only the manpower that we need to be in our facility, we need the equipment. And we are developing a model to demonstrate that even when you have the necessary healthcare workers in the facility and there are no equipment for them, there are no machines for them to use, it's somehow not going to give you the very best. Let me stop here. Thank you.
Yeah, thank you very much. I just realized that we may need not less than 3 hours if we want to really discuss the issues that will make our health workers to leave the country. But the most important is issues relating to welfare, issues relating to the environment, and then the insufficient availability of equipment for people to work with to attain their height and achieve what they want to achieve. Thank you very much, sir. Professor Chingle, Dr. Kefas really did justice to his time. I hope you will do so. You do same, sir. Policy, planning, and financing are very necessary for the maintenance of adequately motivated human resource for health. How do we make human resource for health planning evidence-based and sustainable? It's not here? Okay. Okay, so let me take the next question so that we don't waste time. Dr. Jonathan Blues. Data and evidence are key to decision making. How is human resource for health being used for decision making?
Thank you very much.
Straight to the point, sir.
Thank you very much for the question. I think the question is a follow-up to the question you just asked with regard policy making. The global space is driven by data. And so you cannot just approach the global space without having data. And we've had several discussions this morning, and reference has been made on data ability to key in the data you are generating. Because without the data you're generating, you cannot have access to whatever form of support that you need. Most of my senior colleagues here as academics have discussed the issue of data. You cannot have access to grants or any form of support when you don't have data to back up whatever you are applying for. And so the place of data is very, very important. And then looking at the human resource for health, it's all about the health workforce. What is the health workforce all about? It's all about the clinical and the non-clinical staffs. How do we combine these, because it's a teamwork? So we need to harness these resources at our disposal to really see what we can do before reaching the place of policy making. And so for us to generate and to come up with policy, we must have a robust database. And so it's expected that in an organization, you'll be able to monitor the entry and then the exit of your staffs. The exit could be either by retirement, death, or by transfer out. So as you're monitoring, you don't get to plan at the point of exit. You start planning from the point of entry. So when you have a robust database, you know when a staff is coming into the system and you know when this staff is exiting, and you start planning. You start making preparation for that particular period so that you don't create gap. It takes a lot of resources, especially when you're talking about database at the primary and then the secondary level, because it all needs the willingness. My few months of being at the College of Health, you know, I've had several course visits to the local government chairman, and the discussion is all about how they can key into the human resource that's available at the College of Health, especially with regard to health information management. Because that is a rich database. All they need is to have these competent people that are trained. And then at the point of exit, they are moved into managing the health system in terms of generating and keeping our data. Very, very important. And so we cannot make decisions without the data. You must know how many people are exiting and how many people you need to replace, because resources are lean. We have competing variables with regards to the lean resources that we have at our disposal. And so you will need to make plans. And so data is not just for our policy making. For research purpose, we need data. And data could also be a rich bank for us to be able to connect with the global space and then develop and grow the institution. For us in Plateau Hospital, as an example, we've migrated from less of paper moving into AMRL. Why? Because there are a lot of challenges with paperwork.